Mark, is there any mutational profile that allows us to predict who might respond to a second-gen drug like quizartinib?
Not really. In general, there is a mutational profile that will tell you chemotherapy is really going to be hopeless, and that's the high mutation burden, the high ITD VAF or high ITD allelic burden. Those patients do abysmally. Now, they do abysmally no matter what. We saw it with gilteritinib, a great drug. We saw it with quizartinib. When you have a huge burden of disease, and that's really what you're looking at with a high allelic ratio, that's a troublesome patient population. Try and use chemotherapy on that, it's almost absolutely futile. So that's about the only predictor, I would say, at least in the relapsed refractory setting.
Dan, did you see the data on transplants after quizartinib?
Yeah.
Want to talk about that?
Yeah, well, I mean, I think this is sort of, in many cases, the goal is that's the end point is getting patients to a transplant after, after you can salvage them in the relapse setting. And by the way, not that any of these studies have the capacity to be designed in a non-inferiority way that's too difficult and numbers are too much, but as a clinician, I don't necessarily need to see superiority for a well-tolerated pill when we're talking about chemotherapy. So the fact that we have two therapies out there that in fact are do have a better survival than chemotherapy is just gravy for me. That's way above the bar. But yeah, I mean, I think the message is that these patients can be salvaged in a relatively well-tolerated fashion and can have very promising longer-term outcomes, and maybe we'll see cure. So I think that's the message, and I think that was always the goal. I think
Ganguly gave a very passionate presentation, as I remember it, in the oral session about, from the point of view of a transplanter, pointing out the higher remission rates, good for getting patients to transplant, the longer duration of that remission, good for getting them to transplant, and the lower toxicity, all these things good for transplant.
I mean, I think what he showed, I mean, in this last week, he gave a nice summary, and of course, there's a lot of caveats because there is always internal bias, individual biases when we take people to transplant. We see the patient is never captured, but it was 6 to 7 months with quizartinib alone. If you achieved a remission, went to transplant, went to 12 to 14 months, and if you gave post-transplant, which again is really the key, people will question, and they did in that session, what is the benefit of this one intervention? And I agree, it's marginal, but when you do that intervention and you do the transplant and you do the post-transplant maintenance, and then eventually they show 25 months in that subset who could get remission, transplant, post-transplant, which, I mean, is unheard of. 3 years ago for relapsed FLT3, we would say nobody's going to go more than 5 months.
Well, and this is one of the things that is really undermining our ability to bring drugs along in AML is that bridge to transplant. I mean, at this point, unfortunately, it remains the only curative option for relapsed refractory disease. And so it has to be considered as part of the package.
And yet, the regulatory authorities regard it as an irritation, yes. A nuisance.
Mark, tell us about the drug that did get approved for relapsed refractory FLT3-mutated AML.
So these drugs were actually gilteritinib, followed close on the heels of quizartinib in the developmental pathways, and in fact, they were even being developed together at one point by the same company. And we were all involved in it, and we looked at all the things that can go wrong in a FLT3 mutant or FLT3 inhibitor trial. Not that there's nothing wrong with the drug, but what not to do in your trial, who to include, how to do it. And so the analogy I make with gilteritinib is basically gilteritinib sits back there and watches everybody go on in and spring all the traps and fall in all the holes. And then they just go on in afterwards and claim the prize. And yet, it's a great drug. But in fact, that's why it happened so fast, is we got to learn from all the mistakes we made trying to develop the earlier drugs. And so when we came in with a developmental plan for gilteritinib, it just moved very quickly. It was a well-designed drug. It's extremely well tolerated. It does hit the TKD and the ITD mutation. It does not have KIT suppressive activity, so it's less myelosuppressive. They got a label for CRH, Sierra Bahamas, whatever you want to call it. And a great drug. We're using it in a maintenance trial right now. It's being tested head-to-head against midostaurin in a variety of circumstances. Different than quizartinib. It is less potent. And I still like the concept of quizartinib early on, and maybe gilteritinib later on.
So in that randomized trial, a 2-to-1 randomization, more patients had CR, CR plus CRH, more patients got to transplant, and the endpoint, primary endpoint, median overall survival was improved by using gilteritinib as opposed to chemo.
Big fat difference in the survival curve. You can see it from across the room in those patients, but still everybody dies. Not everybody, but basically only 1 out of 7 is a long-term survivor. With both drugs, we have a lot more work to do.
I think what's really instructive and should be remembered is that the performance of the chemotherapy arm. A lot of people are like, wow, the chemotherapy did very poorly. But Mark, you led the lustortinib study, and the MEC and HiDAC in that study also did miserably.
Yeah, it was fall off a cliff.
Yeah.
This was fall off a cliff survival curve. Again, taking a FLT3 mutant relapsed patient and giving him chemotherapy is, not madness, but in fact, it's a pretty abysmal option. So.
Well, these drugs are being evaluated not only with intensive chemotherapy, with hypomethylating agents, and we'll see where that gets us for that subset of patients who can't get intensive chemotherapy.